In today's episode of FMGE Recall Rush, you will be tested with 25 questions of ENT and you will have only 5 seconds to answer each question before the correct answer and a brief explanation is revealed. Let us know in the comments how many questions you get correct. Let's dive straight into the first question.
Question 1. Identify the sinus marked in the image. Here are the options. A. Frontal sinus. B. Piriform sinus. C. Ethmoid sinus. D. Maxillary sinus. And the correct answer is option D, maxillary sinus. Here's the explanation.
Radiologically, maxillary sinus is also called as antrum of Highmore. It is the first sinus to develop, and hence, since it's the first sinus to develop, won't it be the first sinus to be visible radiologically? Yes, it is the first sinus to develop and the first sinus to be visible radiologically. It is the largest of all the sinuses. So if you see, this is the largest of all the sinuses. When we see all the sinuses, the the maxillary sinus is the largest of all the sinuses. It has got certain walls. This is the base of the maxillary sinus that is separating the sinus from the lateral wall of the nose. So this is called as the base, which is separating the maxillary sinus from the lateral wall of the nose. Then you have got the apex. So this is your apex, this is your base. So base separates the maxillary sinus from the lateral wall of the nose. Here you have got the apex. Then you have got the roof of the maxillary sinus, and then we have got the floor of the maxillary sinus. Then we have an anterior wall and then we have a posterior wall. We'll understand them one by one. So if you see, this is the base of the maxillary sinus. This base is separating the maxillary sinus from lateral wall of the nose. So this is separating the maxillary sinus from the lateral wall of the nose. Then you have got the apex. So this is your region of apex. The apex is at the level of zygoma. So apex of the maxillary sinus as at the level of zygoma. Now this is the roof of the maxillary sinus. Roof of the maxillary sinus is formed by the floor of the orbit. So roof of the maxillary sinus is formed by which wall of the orbit? Floor of the orbit. So roof of the maxillary sinus is formed by the floor of the orbit. Floor of the maxillary sinus is in relation to teeth. Which teeth it is in relation to? Your second premolar and first molar. So here you will have two teeth. What teeth do we have? Second premolar and first molar. So if you see in this diagram, you will understand better that the roof of the maxillary sinus is formed by which wall of the orbit? Floor of the orbit. Floor of the maxillary sinus is in relation to which teeth? It is in relation to your second premolar and your first molar. Then you have got an anterior wall.
Question 2. A 16-year-old boy presented with recurrent epistaxis. There is no history of trauma associated with it. On examination, there is a firm purplish mass on the left posterior choanae. Which of the following is the most appropriate for managing this patient? Here are the options. A. Needle biopsy. B. FNAC. C. Radiotherapy. D. Surgical excision. And the correct answer is option D, surgical excision. Here's the explanation.
Now, what is the treatment for juvenile nasopharyngeal angiofibroma? The treatment is embolization followed by surgical excision. So you have to block the feeding vessel to the tumor and then you have to excise the tumor. So the treatment is embolization followed by surgical excision. Now to reduce the vascularity, we can embolize. We can give a course of estrogen therapy. We can give a course of cryotherapy that would reduce the vascularity of the tumor and then we can do the surgery.
Question 3. A 35-year-old woman takes aspirin for a headache and later presented with wheezing and breathlessness. Along with these two symptoms, what other clinical findings are likely to be found in this condition? Here are the options. A. IgE release. B. Nasal polyp. C. Extrinsic asthma. D. Drug interaction. And the correct answer is option B, nasal polyp. Here's the explanation.
Samter's triad. What is Samter's triad? Samter's triad is asthma, it is aspirin sensitivity, and it is nasal polyposis. So patients who have got a nasal polyp, there is a very high likelihood that they could have asthma as well, and they could be sensitive to aspirin. So aspirin is typically to be avoided in patients who have got nasal polyposis and
asthma, because this triad is present where we know patients can be sensitive to aspirin, and this can cause a reaction, and that could be fatal to the patient. So it is better to avoid aspirin in patients with asthma and who have nasal polyps. So please remember in
Question 4. An elderly diabetic female patient presented with a black, foul-smelling discharge from the nose. On examination, a blackish necrotic mass filled the nasal cavity and eroded the septum and hard palate. What is the most probable diagnosis? Here are the options. A. Aspergillosis. B. Mucormycosis. C. Foreign body. D. Rhinosphoridiosis. And the correct answer is option B, mucormycosis. Here's the explanation.
This mucormycosis is typically a angioinvasive fungus. What is the meaning of angioinvasive? This fungus goes and invades the blood vessel. So say this is the blood vessel that is supplying this tissue. This fungus goes into the blood vessel and multiplies to obstruct the blood vessel. And when it obstructs the blood vessel, what will happen? Will the tissue get blood supply? No. Will this result in tissue ischemia? Yes. When there is tissue ischemia, will there be necrosis? Yes. And when there is necrosis, will you get like this a black discharge? Yes. So this is how you get a black discharge in a patient with mucormycosis. So the word to remember is it is angioinvasive, invades the blood vessel, causes tissue ischemia and necrosis, and they will have a black charred necrosed tissue wherever there is a fungal infection. Now, since it is spreading via blood vessels, it is a rapidly progressive condition. It is extremely rapidly progressive. It spreads very, 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 very fast. So it's a rapidly progressive condition, and here it will spread very quickly to the adjacent sites to cause necrosis. Now, what is the typical sign that you see on an MRI? So if you see here the MRI, you can see the turbinate here is white. But see the turbinate on the opposite side, it is black. So this sign is called as black turbinate sign. So black turbinate sign is again a very important hallmark of mucormycosis.
Question 5. A 60-year-old diabetic presented with severe pain in the ear and otorrhoea not responding to antibiotics. On examination, granulation tissue is seen in EAC and facial nerve palsy was present. The likely diagnosis is, here are the options. A. Otomycosis. B. Serous otitis media. C. Malignant otitis externa. D. Eczematous otitis externa. And the correct answer is option C, malignant otitis externa. Here's the explanation.
Now, what is malignant otitis externa? Is it a malignancy? It is not a malignancy, but does it mimic a malignancy? Yes, it mimics a malignancy because it's an aggressive infection, rapidly spreading infection, present in tissue with ulcers or dead tissue, erosive tissue in the exploratory canal that resembles malignancy. That is why it is called as malignant otitis externa. What is the cause of this malignant otitis externa? Malignant otitis externa again is caused by Pseudomonas, but here the patient is immunosuppressed. So pseudomonal infection in immunosuppressed, especially if the patient is having diabetes, is having any transplant, is on immunosuppressants for any autoimmune disorders, or is immunosuppressed because of HIV or any other immunosuppressive diseases, then the patient can be predisposed to this pseudomonal infection. So typically there will be history of some ear picking with the help of some say earbud or matchstick or some other thing, or there can be entry of water into the exploratory canal, or there can be uncontrolled sugars or diabetes. So some predisposing factor would be present, and that will predispose to this malignant otitis externa. What will be the symptoms of a patient who has this malignant otitis externa? Like I told you, the organism is very aggressive. Patient's immunity is extremely low. It is a rapidly progressive infection. So the patient will complain to you mainly with excruciating ear pain. That will be the main symptom. Severe excruciating ear pain can occur. And since this is an erosive disease, anteriorly the disease can go to the temporomandibular joint, causing pain around the TM joint as well, limiting the movements of the temporomandibular joint. It can erode the floor of the external canal and can involve the facial nerve, most commonly resulting in a facial nerve palsy. It can go through the base of the skull and invade skull base foramina to cause multiple cranial nerve palsy that can involve the jugular foramen to involve the 9th, 10th, 11th cranial nerve. Later, it can go to the hypoglossal canal. It can go from there towards the petrous apex. From there, it can go towards the parapharyngeal, retropharyngeal spaces also. So, it can spread extensively because the patient's immunity is low and the organism is very, very aggressive. So, the main symptom initially will be pain, but progressive symptoms can appear depending upon the extent of spread of disease.
Question 6. Which of the following is part of Trotter's triad, seen in nasopharyngeal carcinoma? Here are the options. A. Conductive hearing loss, ipsilateral temporoparietal neuralgia, palatal paralysis. B. Sensorineural hearing loss, contralateral temporoparietal neuralgia, palatal paralysis. C. Sensorineural hearing loss, ipsilateral temporoparietal neuralgia, palatal paralysis. D. Conductive hearing loss, contralateral temporoparietal neuralgia, palatal paralysis. And the correct answer is option A. Conductive hearing loss, ipsilateral temporoparietal neuralgia, palatal paralysis. Here's the explanation.
What is Trotter's triad? Trotter's triad is the hallmark that you see in NPC. Here, the patient will have conductive hearing loss because of serous otitis media, eustachian tubal block causing conductive hearing loss. Along with that, fifth nerve involvement will result in pain in the area of distribution of the fifth nerve, and then there can be 10th nerve involvement resulting in palatal paralysis.
Question 7. A patient was diagnosed with ear wax and was subjected to syringing to remove the wax. She developed a syncopal episode while doing the procedure when the tip of the syringe touched the ear canal. Which of the nerves is responsible for this episode of syncope? Here are the options. A. Auriculotemporal nerve. B. Arnold's nerve. C. Glossopharyngeal nerve. D. Jacobson's nerve. And the correct answer is option B. Arnold's nerve. Here's the explanation.
What is Arnold's nerve? Auricular branch of the vagus nerve is called as your Arnold's nerve. It will go to supply the floor of the external auditory canal and the posterior wall of the external auditory canal. So if we take the canal, the roof and the anterior wall will be supplied by a auriculotemporal nerve, whereas the floor and the posterior wall will be supplied by Arnold's nerve. Arnold's nerve is nothing but auricular branch of the vagus nerve. Now, since your Arnold's nerve is supplying the floor of the external auditory canal, whenever you're doing a procedure in the canal, like say probing, like say removal of wax, like say you're doing foreign body removal, what can happen? Can there be stimulation of Arnold's nerve? Yes. So whenever there is stimulation of Arnold's nerve, this can cause a reflex which is called as cough reflex. So what reflex will it cause? It will cause a cough reflex. Why do we have a cough reflex? Because Arnold's nerve is a branch of your vagus nerve. Vagus nerve also has got innervation to the larynx. So whenever there is stimulation of the Arnold's nerve, there can be impulses or stimulation of the larynx as well. And when there is stimulation, it will elicit cough reflex. There can be MCQs in your examination that a 50-year-old male presented to the ENT surgeon with complaints of decreased hearing. On examination, there was a wax in the external auditory canal, and when on probing or while removing the wax, the patient coughed. This reflex is mediated via which nerve? You should know that it is via the Arnold's nerve. Also, there can be a vasovagal syncope, because we know that vagus nerve, whenever stimulated, can cause a syncopal attack. So you can remember that when you're doing a syringing, when you're doing a probing or any procedure in the external auditory canal, especially involving the floor of the canal, it can precipitate a vasovagal attack or a syncope.
Question 8. A worried mother brought her 6-year-old unimmunized child to the ER with complaints of fever, cough, and shortness of breath. On examination, a pseudomembrane was noted over the tonsils which bleed on trying to remove, and a bull neck appearance of the neck. Which of the following is the most likely diagnosis? Here are the options. A. Infectious mononucleosis. B. Tonsillitis. C. Diphtheria. D. Candidiasis. And the correct answer is option C, diphtheria. Here's the explanation.
Diphtheria is because of a exotoxin liberated by Corynebacterium diphtheria. So this Corynebacterium will liberate an exotoxin. This exotoxin will go and form a membrane on the tonsil. So it is not a true membrane, but it is a pseudo membrane, because it is not coming from the tonsillar tissue, but it is coming from the tonsillar tissue, but it is coming from the exotoxin of the bacteria. So it is not a true membrane, it is a pseudo membrane. Membranous tonsillitis is pearly white in color. This we have understood that it is pearly white in color. Whereas diphtheria, it is because of the exotoxin liberated by bacteria. So this is dirty white or grayish white in color. So diphtheria will be dirty white membrane or grayish white membrane. So based upon the color also, you can differentiate whether it is membranous tonsillitis or whether it is diphtheria. Now, membranous tonsillitis, we know it is coming from the tonsillar tissue, so it is limited to the tonsil. It does not spread to adjacent site. But diphtheria, it will spread to the adjacent sites. So diphtheria will spread to the adjacent sites because it is from the exotoxin. Exotoxin can go anywhere. So you can see on the palate, you can see on the oropharynx, you can see in the vallecula, you can see in the larynx, in the hypopharynx, the membrane to be spreading. But this you won't see in membranous tonsillitis. Fourth thing, in membranous tonsillitis, when you try to peel the membrane, the underlying surface will not bleed. So on peeling, underlying surface will not bleed. Whereas in diphtheria, whenever there is a toxin that is generating a membrane, when you try to peel the membrane, there is inflammation of the underlying area. It is not dead tissue, it is inflamed tissue, so it will bleed. So in diphtheria, on peeling, the underlying surface will bleed. So this will bleed, whereas membranous tonsillitis won't bleed. In both of them, you will have fever, you will have lymphadenopathy, but toxic features and bull neck are features of diphtheria. So in diphtheria, you will see toxic features, you will see bull neck. These are diagnostic hallmark in diphtheria, which you don't see in membranous tonsillitis.
Question 9. The image given below is from a chronic smoker's oral examination. Identify the lesion given. Here are the options. A. Erythroplakia. B. Leukoplakia. C. Fordyce's granules. D. Koplex spots. And the correct answer is option B, leukoplakia. Here's the explanation.
Keratosis larynx, also called as leukoplakia. Leukoplakia, as you all know, in all the other lesions or other parts of our body also we can get leukoplakia, which happens because of chronic irritation. So leukoplakia happens because of chronic irritation. This chronic irritation can be because of excessive voice abuse, it can be because of smoking, it can be because of tobacco chewing, it can be because of any irritant, exposure to gases, fumes, occupational, all of that can result in chronic irritation. So whenever there is a chronic irritation, there is transformation of the epithelium. So initially there will be leukoplakia, then it can progress to carcinoma in situ and then into invasive carcinoma. So what is the cause of this? Smoking is one of the most common cause of keratosis larynx, also called as leukoplakia of the larynx.
Question 10. A child with bilateral sensorineural hearing loss was given hearing aids which have not been beneficial. Which of the following is the next treatment option for this child? Here are the options. A. Bone-anchored hearing aid. B. Tympanoplasty. C. Normal hearing aid. D. Cochlear implant. And the correct answer is option D, cochlear implant. Here's the explanation.
So cochlear implant, we commonly term it as CI, so we'll understand the indications. There have been a lot of revision in the indication in today's time, but at least as per literature, bilateral severe to profound hearing loss is an indication for cochlear implant. So if anybody is having bilateral severe to profound is more than 70 to 90 decibel of hearing loss, meaning almost in both the ears the hearing is absent or negligible. More than 70 to 90 decibels means the patient will not be able to hear anything much. So more than 70 to 90 decibel hearing loss in both the ears is an indication for cochlear implant. Today there have been revisions where they're doing unilateral implant also, but whenever there is a bilateral severe to profound hearing loss, then you do a cochlear implant. That is as per the textbook recommendations even today as per Scott Brown. But I'll to just mention to you that there have been revisions happening by the cochlear implant group, and there have been a lot of indications for unilateral CI also.
Question 11. A 23-year-old male presents to you with a nasal discharge that has the following appearance on a handkerchief. Presence of which of the following features helps you in diagnosing the condition as CSF rhinorrhea? Here are the options. A. Halo sign. B. Handkerchief sign. C. Schwartz sign. D. Phelps sign. And the correct answer is option A. Halo sign. Here's the explanation.
Called as halo sign, target sign, or double ring sign. Now, when a patient comes to you with trauma, there is blood in his nasal cavity, and along with that you can have CSF rhinorrhea. How do we know that this is CSF? Is this only blood? Is it a mix of both CSF and blood? Is this nasal fluid and blood? How do we understand? You have to take the secretions on a Wattman's filter paper. What you will see is a central red dot of blood, and surrounding that you will have a peripheral halo. So this peripheral halo is suggestive of CSF. So this sign is called as double ring sign or target sign or halo sign, which is suggestive of traumatic CSF rhinorrhea. So this is suggestive of traumatic CSF rhinorrhea. So only in traumatic CSF rhinorrhea you get this halo sign or the double ring sign.
Question 12. What clinical test is depicted in the image? Here are the options. A. Epley's maneuver. B. Heimlich maneuver. C. Cottel's test. D. Trotter's method. And the correct answer is option C. Cottel's test. Here's the explanation.
What is Cottel's test? Cottel's test understands or helps us understand the patency of the internal nasal valve. So this is your MCQ. Why are we doing this test? This test helps us understand the patency of internal nasal valve. I have already explained to you what is internal nasal valve in the anatomy class, but to again brief you about it, internal nasal valve is the narrowest portion of the nasal cavity. Now, since this is the narrowest portion of the nasal cavity, we need to know the boundaries. The boundaries of internal nasal valve are: medially you have the septum, superiorly you have the lower border of the upper lateral cartilage, and inferiorly you have the head of inferior turbinate. So you have the upper lateral cartilage superiorly, inferior turbinate inferiorly and laterally, and medially you have got the septum. Now, if you have a patient who's having a deviated nasal septum, what is happening? Is it not compromising your internal nasal valve? Yes. So will the patient have nasal obstruction? Yes. Now, to understand whether this internal nasal valve has got compromised or not, how will we understand is it compromised or not? It is by doing this test called as the Cottel's test. So what do we do in this Cottel's test? The patient is asked to breathe in and breathe out normally first. Then what do? He'll tell, ma'am, I'm having right-sided nasal obstruction. He'll say, okay. And now you'll take your two fingers, not one finger, you're going to take your two fingers and you're going to pull the cheek away on the side where the patient told you he's having difficulty in breathing. So patient told right side, so you're going to pull the cheek away on the right side. Again, breathe in and breathe out. You must instruct to the patient. He says, yes, ma'am, I'm able to breathe better when I'm pulling my cheek away. So when you pull the cheek away, if the patient is able to breathe better, it means that there is obstruction at the internal nasal valve. And if you do the correction of the septum, the patient's breathing will improve. So to understand the patency, how patent or not is your internal nasal valve, you're going to do your Cottle's test.
Question 13. A middle-aged man presents with the following lesion on his face. He has a history of acne rosacea. The condition is. Here are the options. A. Rhinophyma. B. Rhinoscleroma. C. Rhinosphoridiosis. D. Scleroderma. And the correct answer is option A. Rhinophyma. Here's the explanation.
Rhinophyma is also called as potato nose. So this is also called as potato nose. What is the cause of rhinophyma? The cause of rhinophyma is hypertrophy of the sebaceous glands in patients with acne rosacea. So what happens here is there is hypertrophy of which glands? There is hypertrophy of the sebaceous glands. And this is happening secondary to which conditions? Secondary to acne rosacea. And this is seen not just following acne rosacea, it is also seen in elderly patient. It is also seen in diabetics. And what happens here? There is hypertrophy of which glands? Very importantly, there is hypertrophy of the sebaceous glands. Now, this will be your MCQ question. Which gland is hypertrophied in a patient with rhinophyma? It is the sebaceous glands. Now, what will be the symptom? Obviously, nobody likes to have that big nose, wide nose, and that, hypertrophic gland nose. Everybody will be concerned only of cosmesis. It will not cause any symptom at all. Mainly, they will have cosmetic appearance of the nose is what is bothering to these patients.
Question 14. A 65-year-old male presented with a history of dysphagia, halitosis, and aspiration pneumonia. A barium swallow was done and is given below. What is the diagnosis? Here are the options. A. Diffuse esophageal spasm. B. Achalasia cardia. C. Zenker's diverticulum. D. Esophageal cancer. And the correct answer is option C, Zenker's diverticulum. Here's the explanation.
So what symptoms will you see in a patient with pharyngeal pouch? So if you see, the first thing is the mouth of the sac is wider than the mouth of esophagus. So this is where you have the esophagus. This is your oropharynx going to the hypopharynx, and from the pharynx you have the esophagus. So if you see that the mouth of the sac is going to be much wider than the mouth of esophagus. So when the patient takes a swallow, the swallow or the bolus will go preferentially into the sac and not into the esophagus. So what will happen? The patient will feel he's eating food, but it is not going in the stomach. Normally when we eat food, we feel that area, that our stomach is getting full, that satiety level is achieved. Slowly we start feeling full, and at certain point we understand that feeling of fullness. But here the patient really doesn't understand that his stomach is getting full. So that is the first symptom where the patient is not getting a feeling of satiety or fullness. So here the food does not enter the stomach, and the food preferably enters the wide mouth diverticulum. So patient does not feel the fullness. Now over 2 or 3 swallows, 4 or 5 swallows, the sac is getting filled with more and more food. And when the sac is getting filled with more and more food, there will be some gurgling sounds that will come. That gurgling sound is called as a sign, which is called as the Boyce's sign. Okay, so this sign is called as Boyce's sign. So gurgling sounds that occur on swallowing, that sign is called as Boyce's sign. Now again the patient will take more and more food, and the entire sac will get filled with food, and now it is going to compress upon the esophagus. Now that it starts showing compression upon the esophagus because the entire sac is filled with food, the patient will start complaining of dysphagia now. So is dysphagia an early symptom or a late symptom? Dysphagia is a late symptom and not an early symptom. So dysphagia is seen, but it is not in the early part of the swallows, it is in a later part of swallows. And finally, the patient is tired, he is eating, food is not entering the stomach, there are some gurgling sounds, and then ultimately is having even difficulty in swallowing. He'll go to sleep. And when he goes to sleep, the contents of the sac will fall on the larynx. And once the content of the sac falls on the larynx, will the patient cough? Yes. This sort of a cough is called as sleep cough. So sleep cough occurs because of regurgitation of the contents of the larynx, of the pouch on the larynx. So if there is regurgitation of the contents of the pouch on larynx, the patient will cough, and that cough is called as sleep cough. So to summarize, in the first part, patient does not have satiety. Later, the pouch is getting filled with food, producing gurgling sound. The third part, it is going to compress the upper esophagus to cause dysphagia. And lastly, he'll sleep and the content will fall on the larynx to cause sleep cough. Now, how do we diagnose this? This study that you see here is called as a barium swallow. So, a barium swallow is done to diagnose this. So what is barium swallow? A meal mixed with barium is given to the patient, and once the patient takes this meal, it goes into the pharyngeal pouch and into the esophagus. Now once you give a barium meal and then do an X-ray, you will be able to identify the sac. So barium meal is given and then you do an X-ray and you will be able to identify this sac. So this X-ray, what we do is called as a barium meal X-ray, and this is how you diagnose the pharyngeal pouch. So pharyngeal pouch is diagnosed on a barium meal.
Question 15. Identify the marked structure in the endoscopic image of nasopharynx. Here are the options. A. Sinus of Morgagni. B. Passavant's ridge. C. Fossa of Rosenmuller. D. Rutgers pouch. And the correct answer is option C, fossa of Rosenmuller. Here's the explanation.
Now, the most common site of origin of nasopharyngeal carcinoma is from the fossa of Rosenmuller. So, if you see, this is your opening of eustachian tube. Behind the opening of eustachian tube, you see there is a cushion. This cushion is called as torus tubarius. So, that cushion is called as torus tubarius. Behind that cushion, you see a recess. This recess is called as a fossa of Rosenmuller. So, what are the structures? So, this is your eustachian tube. Behind the eustachian tube, you have a cushion. This cushion is called as torus tubarius. And behind the torus tubarius, you have a fossa. This depression is called as fossa of Rosenmuller. So, this is called as fossa of Rosenmuller. The most common site of origin of nasopharyngeal carcinoma is from this fossa of Rosenmuller. So, fossa of Rosenmuller is the most common site for origin of nasopharyngeal carcinoma.
Question 16. Most common cause of malignant otitis externa. Here are the options. A. Staphylococcus aureus. B. Streptococcus pyogenes. C. Haemophilus influenza. D. Pseudomonas aeruginosa. And the correct answer is option D, Pseudomonas aeruginosa. Here's the explanation.
What is the cause of this malignant otitis externa? Malignant otitis externa again is caused by Pseudomonas.
Question 17. Epstein Barr Virus cause? Here are the options. A. Juvenile nasopharyngeal angiofibroma. B. Nasopharyngeal carcinoma. C. Stewart's granuloma. D. Rhinoscleroma. And the correct answer is option B, nasopharyngeal carcinoma. Here's the explanation.
One of the very important predisposing factor is Epstein Barr virus, which is often forgotten because we remember all the environmental triggers, but we often forget the incidence of EBV causing nasopharyngeal cancer.
Question 18. Office headache is due to? Here are the options. A. Maxillary sinusitis. B. Ethmoid sinusitis. C. frontal sinusitis, D. Sphenoid sinusitis. And the correct answer is option C, frontal sinusitis. Here's the explanation.
Frontal sinusitis, there is a specific thing that you should remember. I told you they will complain to you with pain over the forehead, but there is something called as periodicity, or also called as office headache. What is office headache? When the patient wakes up in the morning, the patient will have headache. But as the day passes by, in the evening, the patient will have no headache. So this is called as periodicity, also called as office headache.
Question 19. High tracheostomy is done in which of the following? Here are the options. A. Laryngeal papilloma. B. Total laryngectomy. C. Bilateral vocal folds palsy. D. Laryngomalacia. And the correct answer is option B, total laryngectomy. Here's the explanation.
Mid tracheostomy. So if you do anywhere above the second, meaning at first tracheal ring, we call it as high tracheostomy. Now, why do we not want to do a high tracheostomy? Because if you go higher, are we putting the subglottis at risk for stenosis? Yes. So there is a risk for subglottic stenosis. And hence we do not do this commonly. But when do we do this? What is the indication for high tracheostomy? Now say you are doing a laryngectomy. After doing laryngectomy, will you keep one ring of trachea and do a tracheostomy of second ring? No, but instead from the first ring itself you will do a permanent tracheostomy, because above that you have disconnected, right? So you will do high tracheostomy. The indication is for patients with laryngeal carcinoma who are undergoing total laryngectomy. So patients who are undergoing total laryngectomy, in these patients you will do a high tracheostomy.
Question 20. Which of the following muscles is the life-saving muscle of the larynx that pulls back vocal cords in order for breathing to take place? Here are the options. A. Cricothyroid. B. Posterior cricoretinoid. C. Lateral cricoretinoid. D. Transverse arytenoid. And the correct answer is option B, posterior cricoretinoid. Here's the explanation.
During respiration, when you want to breathe, the air has to go inside. So should the vocal cords come to midline or should they go away? They have to go away. And when you want the vocal cords to go away, should an adductor come or an abductor come? An abductor has to function. And which is the only abductor of your vocal cord? It is your posterior cricoarytenoid. So the only abductor is your posterior cricoarytenoid. We don't have any other abductors. So the posterior cricoarytenoid muscle is the only abductor of the vocal cord, and this helps in respiration. So when we want to breathe, we want the vocal cords to go away from the midline, and this is done by your posterior cricoarytenoid muscle.
Question 21. Picket fence fever is seen in. Here are the options. A. Lateral sinus thrombophlebitis. B. Quinsy. C. Laryngitis sicca. D. Croup. And the correct answer is option A, lateral sinus thrombophlebitis. Here's the explanation.
So what is happening? All of you can make out this is your sigmoid sinus and this is the bone that is covering the sigmoid sinus. So the disease from the middle ear has gone to the mastoid bone, and now when it has gone to the mastoid bone, initially what you will see, there is inflammation of the bone or the outer part of the blood vessel, which we call it as periphlebitis. Then the endothelium will be involved to cause endophlebitis. Now when there is endophlebitis, there is organization of platelets, which we call it as thrombosis, and this will result in a lateral sinus thrombosis or a lateral sinus abscess. So this is the pathogenesis. So initially the bone is intact, then the bone is eroded to cause periphlebitis, then endophlebitis and aggregation of platelets, and that abscess can occur in the lateral sinus or sigmoid sinus, or there can just be a thrombus also. So whenever we have a lateral sinus thrombosis, we have a typical type of fever which we call it as hectic picket fence type of fever. What is hectic picket fence type of fever? The patient will have a spike of fever even before it touches the baseline. There is another spike of fever. So it's very hectic, occurring again and again, and it resembles the fence of a garden. So this type of a fever we call it as hectic picket fence type of fever.
Question 22. Which of the following muscles originates from the first pharyngeal arch? Here are the options. A. Stapedius muscle. B. Anterior belly of digastric muscle. C. Posterior belly of digastric muscle. D. Stylopharyngeus. And the correct answer is option B, anterior belly of digastric muscle. Here's the explanation.
So when we see the first arch or the mandibular arch, what structures we should remember? The muscles of mastication, the muscles that are responsible for opening the eustachian tube, the tensor veli palatini and the tensor tympani are two muscles that you should remember. So the first thing is muscles of mastication. One muscle that helps in opening the eustachian tube, that is your tensor veli palatini and your tensor tympani. So if you see the first arch derivatives, we get the muscles of mastication, tensor veli palatini, tensor tympani, mylohyoid, and we have got anterior belly of digastric.
Question 23. Continuous watery discharge from the nose after trauma is most likely a feature of. Here are the options. A. CSF otorrhoea. B. Common colds. C. CSF rhinorrhea. D. Anterior epistaxis. And the correct answer is option C, CSF rhinorrhea. Here's the explanation.
So what we understand by the term CSF rhinorrhea is if there is leak of CSF, which is the fluid that surrounds the brain, into the nasal cavity and presents as a discharge. Rhinorrhea means nasal discharge. So if there is CSF as the nasal discharge, we call it as CSF rhinorrhea. Now, why do we get CSF rhinorrhea, or why do we get a fluid that surrounds the brain into the nasal cavity? There has to be some defect. So typically, if we take the nose, we have the roof of the nose that separates the nasal cavity from the anterior cranial fossa. So we have the brain, typically the frontal lobe. Sometimes it can happen from the middle cranial fossa and posterior cranial fossa also. We can get CSF rhinorrhea, but commonly we get it from anterior cranial fossa only. So the frontal lobe is present in the anterior cranial fossa. This is surrounded by a fluid which is called as CSF. Now surrounding that we have got layers of meninges, the dura mater, the pia mater and the arachnoid mater. So whenever there is a defect or a breach in the bone and breach in the dura, the CSF can leak from the cranial cavity and can present into the nasal cavity, and from the nose it can present as the nasal discharge. So what should be there? There has to be some communication between the nose and the brain or the roof of the nose. As a result, the fluid is leaking into the nasal cavity. It can happen also from the paranasal sinuses if there is a defect of the frontal sinus, the sphenoid sinus or the roof of the ethmoid sinus. Then also we can have the CSF rhinorrhea. Now the commonest cause why CSF rhinorrhea would occur would be because of trauma. Now we've understood there has to be a defect in the bone. Now this defect is usually because of trauma, and the most common site is cribriform plate of the ethmoid.
Question 24. Adam's apple seen in boys is because of. Here are the options. A. Hyoid bone. B. Tracheal rings. C. Thyroid cartilage. D. Cricoid cartilage. And the correct answer is option C, thyroid cartilage. Here's the explanation.
Adam's apple is nothing but the thyroid cartilage. So I'll compress on the Adam's apple and I'll ask the patient to speak. Now when I compress on the Adam's apple and the patient has a male quality of voice, or there is a change in the voice, does it mean that it was because of the stretch in the vocal cord? Yes. And that test we call it as Gutzman pressure test.
Question 25. A 35 years old female presents with tinnitus, vertigo and fullness in ear. Likely diagnosis. Here are the options. A. Meniere's disease. B. Otosclerosis. C. Ototoxicity. D. Noise-induced hearing loss. And the correct answer is option A. Meniere's disease. Here's the explanation.
Is Meniere's disease. Meniere's disease is a triad characterized by VST. What does V stand for? V stands for vertigo, S stands for sensory neural hearing loss, and T stands for tinnitus, which is nothing but ringing sound in the ear.
Next up is a subject that has a love-hate relation with the students. Join us tomorrow for a quick mock session of OBG. Like and subscribe if you learned something new today. See you in the next one.